All right, so this is ATI Chapter 25, Medications Affecting Coagulation. We have quite a few drugs that are listed here. They kind of fall into different categories, but the good thing is that they all kind of relate back to that clotting process that we learned in patho. So we're going to kind of try to relate it back to that, which means we're going to have to review the whole process of clotting, just in case you can't remember. So if we remember, for clotting, there are 13 blood clotting proteins that are, or 13, blood clotting proteins that are found in the blood. So these are things that are made by the liver. So this is one of the reasons that liver problems or liver failure can lead to clotting issues. And so they kind of float around and they're in an inactive state most of the time. Let's see. So you can kind of see that here's, I guess we can look at one of the more common ones. Here's factor 10 or factor X. So this little X, and then it goes to XA, A in my mind meaning activated. That's probably what it means, but that's what I always think of. So the activated form and the inactive form, which is floating around. So we see the intrinsic extrinsic pathway. The intrinsic pathway, blood or vessel injury, and the extrinsic system or extrinsic pathway comes from like tissue damage or something like that. We're not too worried about that, but because they both end in the activation of factor 10. And factor 10 is kind of a big deal, and we'll see that because we have a couple of drugs down here that inhibit factor 10 or the activated form of it. So either the intrinsic or extrinsic pathways activate factor 10 or factor X. Factor X is activated to form factor 10A, and 10A then will convert prothrombin, which is also called factor 2, so you'll see that written sometimes. So prothrombin to thrombin, and then thrombin will cause fibrinogen to turn into fibrin, and fibrin is what forms that mesh. So if you, oops, that's kind of terrible. So these are blood cells, platelets, okay, so kind of all get trapped in this mesh, okay, and that's what a clot is. And that mesh, or these fibers, are fibrin. Okay, so that's really what we're trying to accomplish here. I will also say that the platelets aggregate, and that's what starts the clotting process, or that's part of the clotting process, I should say. And so that's going to come into play in a little while too. So if we figure out, or if we think that activation of factor 10 is a really important thing because that factor 10 turns the prothrombin into thrombin, then we have a couple of drugs, fondaparinux, which indirectly inhibits factor 10A. I'm not too worried about directly, indirectly. Rivaroxaban is called a direct X or 10A inhibitor, and the only difference is that whereas rivaroxaban directly binds to 10A, fondaparinux will kind of indirectly do it via antithrombin, and we'll talk about antithrombin here in a minute. So we have a couple of drugs already, and we kind of know their mechanism. They just bind to that factor 10A. And then thrombin, so the next step for thrombin, converting fibrinogen to fibrin, well, dabigatran is a drug that inhibits thrombin. So it actually blocks thrombin, so thrombin can't, or oops, that's prothrombin. So it blocks thrombin, so thrombin can't turn that fibrinogen into fibrin. So that's a couple of mechanisms, 3 drugs, two mechanisms right there. Fibrin is a fiber that creates the mesh of platelets. So another thing that you can see from this picture up here, diagram, whatever you want to call it, is that I've written vitamin K in here. So vitamin K is a cofactor, and all a cofactor does is you usually, you have an enzyme or something like that, and a cofactor will bind a part of that enzyme and then turn it into an active form. So it activates it in a way. So so the enzyme is ready to go, but it needs that cofactor to activate it. Well, vitamin K is that cofactor for about 4 of these cofactors. So there's another drug, warfarin, which blocks vitamin K. So if vitamin K can't bind to these cofactors and activate them, then they remain inactive. So that's the mechanism of warfarin. So we can see here are the mechanisms just of those first three. It's just a different kind of picture you can look at. All right, so we haven't talked about antithrombin. Antithrombin is also made by the liver, and it's there to kind of stop clotting. Okay, so it prevents clotting. And it interacts with several clotting factors. Those are all kind of listed here. I'm not going to name each one of them. But that's what antithrombin does. So there are a couple of drugs, heparin and enoxaparin, and these are both heparin. So enoxaparin is just a shorter form of heparin. Heparin is this long molecule, and enoxaparin is just shortened. It's just kind of cleaved off. And so we call it a low molecular weight heparin, but it's still basically heparin. It's just not that whole complete protein. So there are a couple of others, and that's what they do, is they kind of hold that antithrombin onto these molecules and onto these clotting factors and keep them from being activated, so they can't be activated. So that's how those drugs work. Now, platelet aggregation. Platelet aggregation is something else that happens, and that's one of the earlier steps in clotting. So that happens before the fibrin mesh and stuff moves in. And that really occurs, so platelets are usually going around and they're not active, they don't stick to each other. And so what it takes is something like tissue factor, something from, and I usually think of it as something that finds itself inside the blood that's not supposed to be there. That's kind of how I think about it, because the blood is, or the blood vessels and the blood inside the blood vessels is supposed to be just kind of unintruded. Nothing is supposed to be getting in there. So when something does get in, it's kind of a signal that damage has been done. So some examples of that are collagen. Collagen is supposed to be found in tissue. It's not supposed to be found floating around in blood. So when it's there, it can activate these platelets, and then it can cause them to become sticky, and they start to stick to each other. ADP is another molecule, and I'm mentioning it because we're going to have a drug. This drug, clopidogrel, blocks ADP binding to platelets. So when ADP is found, then it will bind to these platelets, and that will cause activation of them. Okay. Thromboxane is actually made from platelets. Thromboxane A2 is made from platelets, made in platelets, and that also will kind of increase platelet production, cause some vasodilation, and it causes can contribute to platelet activation and platelet aggregation and activation and aggregation. Okay, so if we just think about those, then we can kind of fill in how these drugs work to prevent that platelet aggregation. So clopidogrel, as we mentioned, blocks ADP binding to platelets. Okay, so that sort of slows or prevents their activation. Thromboxane A2. Now, I didn't put the little chart up here, but remember, NSAIDs and thromboxane A2 block this enzyme called cyclooxygenase, or COX. And by doing that, it prevents the formation of prostaglandins. So that's how we talk about its anti-inflammatory mechanism. But it also slows the production of thromboxane A2. And thromboxane A2, since it's involved in platelet aggregation, platelet production, then that's going to prevent it. So by interrupting that COX pathway, you can prevent that. And there are other sort of side mechanisms involved in that. But I think that's if you think about aspirin as being a drug that blocks that cyclooxygenase, but ultimately in a couple of different ways, it blocks the formation or the production of TXA2, which is going to, again, prevent or slow activation of the platelets. Abciximab, MAB meaning monoclonal antibody, is an antibody. It's just an antibody that will stick to, let's see, how am I going to draw this? It's supposed to be a Y. Okay, so that's supposed to be an antibody. So, but it will stick to these glycoproteins. So we call it a glycoprotein inhibitor, but it's a specific glycoprotein, 2B3A, that sits on the platelets, and when it's activated, then, or when the platelet is activated, then what happens is things like von Willebrand factor, fibrinogen, these things can bind to it, and that's what can cause those platelets to stick together. Okay, so abciximab was developed probably like I should probably check on that, but it's probably like an antibody from a goat or a horse or something, and it will selectively stick to this glycoprotein and prevents that from allowing these platelets to stick together. Okay, so that's gosh, I don't know how many we've gone through. 1, 2, 3, 4, 5, 6, 7, 8, 9 already. Okay, and so we have 9 out of 11. So now we have one more step in the clotting process, and that's to get rid of the clot. And this one should sound familiar to you already because it's tissue plasminogen activator, and we already learned about that for things like stroke, when someone is having a stroke or an MI, myocardial infarction. So anywhere there's a clot that you want to get rid of. So that last step is this is to produce a protein called plasmin from plasminogen. So plasminogen is the inactive form, plasmin is the active form, and plasmin will break down fibrin. Okay, so this fibrin mesh. So plasmin comes in and it just cleaves it, and it cuts it into little pieces, which actively gets rid of the clot. And that's a big difference, because these others were preventing clotting or preventing platelet aggregation. Plasmin will actively break down the clot. So it's activated by something called plasminogen activators, which makes sense. And alteplase, also called TPA, is a plasminogen activator. Okay, so it activates that plasminogen, causes the breakdown of the clot. There are other plasminogen activators. Tissue plasminogen activator is the one that's used, though. Okay, so TPA is plasminogen activator, ultimately causes the breakdown of the fibrin mesh, actively dissolving the clot. So there's one that we haven't talked about, and we'll get back to it when we come across it. But let's kind of quickly go through each of these drugs individually to one more time to just kind of talk about their therapeutic uses, complications, that kind of thing. So the first one, heparin, increases activity of that antithrombin, interrupts the clotting cascade, inhibits that fibrin mesh formation. Okay, so it interrupts the process by increasing that activity of antithrombin, which works on a lot of factors. So therapeutic use, conditions necessitating prompt anticoagulation activity, evolving stroke, pulmonary embolism, and massive DVT. Adjunct during open heart surgery or renal dialysis. Low dose therapy for prophylaxis against post-op venous thrombosis. Okay, so hip, knee, abdominal surgery. One of these surgeries that can cause a thrombus to form, and then a lot of times those go in and cause like a pulmonary embolism or something. Or stroke, or wherever the clot goes. So treatment of disseminated intravascular coagulation. That's usually when you run out of clotting factors, so maybe this is to preserve those. Okay, so complications, hemorrhage. So we're going to see that a lot. Hemorrhage, bleeding, secondary to heparin overdose, because these things are preventing bleeding, so that can be a problem if bleeding starts in another area and causes a hemorrhage. Heparin-induced thrombocytopenia, thrombocytes being platelets, and so that's a low platelet count. Hypersensitivity reactions, so that's allergies type of thing, chills, fever, urticaria, and then toxicity overdose. And so you would administer another molecule called protamine, or drug called protamine, and protamine is supposed to kind of bind to the heparin and inactivate the heparin. Okay. Enoxaparin, this is that low molecular weight heparin. So it's still heparin, but it's cut off, so it's shorter. So it's a shorter structural form of heparin, increases activity of antithrombin, so it does the same thing that heparin does. Okay, increases that activity of antithrombin and blocks all those factors. So primary uses: prevent DVT in post-op patients, treat DVT in pulmonary embolism, and prevent complications in angina, non-Q wave MI, ST elevation MI, so myocardial infarction. So adverse effects: couple of them that are different here. So hemorrhage, obviously, is one of them. Neurologic damage from hematoma formed during spinal and epidural anesthesia. So this is bleeding into the brain that can happen. So thrombocytopenia, evidenced by low platelet count, and then toxicity or overdose. And administer protamine again. So protamine is actually more effective against enoxaparin, the low molecular weight heparin, but it's used for both. All right. So parenteral. Oh, I forgot to mention that. These are parenteral anticoagulants. So that's their administration rather than oral. We'll get back to the orals later. So another one is fondaparinux, and that inhibits activation of factor 10A, and this is the one that works indirectly. We'll see the rivaroxaban later. I said that wrong, but that directly inhibits it. So this is an indirect inhibitor of factor 10A. It works via antithrombin, but it is selective, more selective to 10A. Prevents DVT in post-op patients, treats DVT and pulmonary embolism in conjunction with warfarin, so it can be used with warfarin, which we'll talk about. Adverse effects, hemorrhage, neurologic damage from hematoma formed during spinal or epidural anesthesia, thrombocytopenia evidenced by a low platelet count. I don't think I left this in there from the previous slide. I think this is for fondaparinux, but I'll check it and change it if I have to. All right. Warfarin. So warfarin is our vitamin K antagonist. So it blocks vitamin K, which prevents the synthesis of these 4 coagulation factors that vitamin K is a cofactor for. So treatment in venous thrombosis, treatment of thrombus formation in patients who have atrial fibrillation or prosthetic heart valves. Remember that heart valves can cause some clotting. So warfarin is okay for that in this case. Prevention of recurrent MI, transient TIAs, transient ischemic attacks. So these are those very quick, almost to stroke but not damage. Don't last very long. So stroke kind of things. PE, pulmonary embolism, and DVT, deep vein thrombosis. So adverse effects, hemorrhage, hepatitis. So the liver can get involved with this one, with warfarin, and that's something we may have already seen before. With warfarin, and it's, you know, we've come across warfarin just because it interferes with other drugs. Toxicity or overdose. Well, yeah, I mean, that makes sense that if you give too much, but since it's blocking vitamin K, one of the treatments for that would be to just administer vitamin K and see if that kind of works. Okay, so direct thrombin inhibitors. Okay. So thrombin directly, so Dabigatran directly inhibits thrombin, and which is going to prevent that fibrin mesh from forming and a clot from developing. So it prevents a thrombus from developing. So prevents stroke or embolism in patients who have atrial fibrillation not caused by valvular heart disease. Okay. So that was different than what we saw for warfarin. So DVT treatment, prevention of PE. Adverse effects, bleeding, yes. And this one, Dabigatran, has GI effects, nausea, vomiting, esophageal reflux, ulcer formation, and it kind of mentioned in ATI, it said other effects, and back pain. So back pain is one of these. Back pain, hypotension, headache. Okay, so that can be experienced. Okay, so rivaroxaban is a direct 10A inhibitor. So it directly and selectively inhibits factor 10A, which in turn prevents the formation of thrombin. Okay. Primary therapeutic use, AFib, atrial fibrillation. So remember, atrial fibrillation or fibrillation in general is where you don't have good contraction of the heart. It's more of it's a disorganized kind of quivering, which means that you can have some stasis of blood flow, which can cause clotting. So rivaroxaban can be good for that. Prevention of DVT and PE in patients undergoing total hip or knee arthroplasty. Okay, so again, we don't want clots to form, and then those clots to go clog up something else like a pulmonary embolism or something. Prophylaxis for stroke, so prophylaxis is prevention for stroke and embolism in patients who have non-valvular atrial fibrillation. Okay, adverse effects, bleeding, and then also liver involvement. Okay, so elevated liver enzymes, bilirubin might show up, and that would be a concern. So let's see how quickly we can go through the antiplatelets. So these things that are preventing platelet aggregation. So the first one is aspirin. So it inhibits platelet aggregation primarily by inhibiting cyclooxygenase and the formation of thromboxane A2. So uses, a lot of people take aspirin prophylactically. So, and you'll see that these are a lot of what we see here. So prevention of acute MI. So people who are at risk or might be at risk, aspirin seems to be pretty safe for that. So prevention of acute MI, prevention of reinfarction in clients following an acute MI. So that means they had a heart attack, so then they'll go home and they'll be taking aspirin from that point on. Prevention of ischemic stroke or TIA, so stroke too. So adverse effects, we're kind of familiar with some of these GI effects: nausea, vomiting, dyspepsia. Hemorrhagic stroke can happen, that's too much bleeding, prolonged bleeding time, gastric bleeding, so bleeding in the stomach, thrombocytopenia may happen, and then tinnitus and hearing loss are also associated with aspirin. Okay, abciximab, that is our monoclonal antibody. Inhibits platelet aggregation by binding to that glycoprotein, the glycoprotein 2B3A that's found on the surface of platelets. So it binds to that, blocks that, so the platelets can't aggregate because they need that protein to aggregate. Acute coronary syndrome is a use for this. Acute coronary syndrome is used during and after coronary artery procedures to prevent clot formation within the coronary artery. So abciximab, clopidogrel are useful for that. Adverse effects, hypotension, bradycardia, that's different. Hypotension, bradycardia slows the heart, drops the blood pressure. Prolonged bleeding time, gastric bleed, thrombocytopenia, bleed from cardiac catheterization site, which I also haven't seen that one in others. Clopidogrel mechanism inhibits platelet aggregation by binding to ADP binding site. So this is our ADP receptor inhibitor. So prevention, therapeutic uses, prevention of acute MI, prevention of reinfarction in clients following an acute MI. Okay, so we saw that before. Prevention of stroke, TIAs, and acute coronary syndromes, along with abciximab. So adverse effects, prolonged bleeding time, gastric bleed, thrombocytopenia, and then the GI effects, diarrhea, dyspepsia, pain. Okay, so this, let's see, this is the only one that we haven't already been through, pentoxifylline or pentoxifylline. The mechanism is it reduces, it's a complicated mechanism, cellular mechanism that involves cyclic AMP and either adenylyl cyclase, I think is the one that's involved in this, not diacylglyceride, but it's these internal mechanisms that are interrupted that causes kind of a host of different effects. So we're not going to worry too much about that. But it reduces blood viscosity. Okay, so I guess you could say in this case it actually thins the blood, as opposed to a lot of people like to call things like heparin a blood thinner, which really that just prevents clotting. But this actually decreases the blood viscosity, so which decreases the potential for platelet aggregation and thrombus formation. And ATI also says that it's an arterial vasodilator, so that can also kind of help blood flow. It helps blood flow along to prevent that clotting. Reduces pain. So these are the listed uses for it. Reduces pain, cramping, numbness, or weakness of extremities due to intermittent claudication due to peripheral artery disease. So that means that clots or blockage of blood flow that can happen intermittently, and that can cause pain. This will kind of prevent that from happening and prevent that pain. And that's really its primary use. Adverse effects, not too bad. GI effects, dyspepsia, nausea, vomiting. And then our last one, our favorite, TPA, alteplase. So that activates plasmin from plasminogen, which breaks down fibrin, which dissolves existing clots. And that's the big difference. This one is not preventing, it is actively dissolving the clots. So used to treat acute MI, so person having an MI, massive pulmonary embolism, treat ischemic stroke, and restore patency to central IV catheters. And the adverse effects of this is bleeding. So if you have clotting that's happening somewhere else, then that can cause those clots to kind of break down too, and can cause bleeding to happen, or bruising, or something like that. Okay, well that's it for this chapter.